Most people see an air ambulance and think, okay, someone is very sick. Dr. Shalini Nalwad sees it differently. For her, it's an ICU in the sky, a second chance at life. She's built India's only flying ECMO program, has saved 365 people who had no other option, flown into active war zones, set 2 world records in CPR, and somehow built 7 organizations across 4 countries while doing all of this. This is one of those conversations you're going to want to sit down for. Welcome to Journal of a Leader, Dr. Shalini Nalwad. You're on the plane. It's landing in Tripoli, Libya, and you see a bomb going outside the window. What do you feel? What do you see?
Of course, like it's human to get panicked, overwhelmed by the situation because you're a doctor, not a soldier, to be in war zone and face these wars. Initial reaction is, okay, what next? And then you can't freeze. You can't be a scared doctor because scared doctor is a disaster. So no matter what our feelings are inside, we have to compose and have a brave attitude towards this. Here, we always say in our aeromedical world, crew safety come first because already there's a patient, but you can't put the crew at risk for a patient. So that's the first thing that comes into your mind. How am I going to get my crew out of the situation? And then if patient is already with us, then of course the patient also takes a priority. So we have to ensure both the patient and the crew is out of the situation as soon as possible. The second thing is we are trained to deal with the situations going through our protocols in mind. And this is the reason why we do have training sessions, we do debriefs, we do run through scenarios, we do moulages, we call it. That means we run through these scenarios. So these kind of protocols and SOPs, they're always ingrained in our mind and they just run through us. And what is the next step we have to do? So
When you saw that, were you scared or did your brain suddenly shift into doctor mode?
no, I shifted into a doctor mode, of course, because scared, you will be scared. But again, as I said, I think it's better to be not, you can't be a scared doctor.
Right.
So we will focus on to being a doctor first, take care of the patient, take care of the crew, because any aeromedical mission, the doctor in charge is the commander in chief. Because if we have to do an emergency landing, we are the one who's asking for it. When we have to take off or fly at a sea level altitude, we ask for it. So these kind of a request or command comes from the medical team. Pilots just they have to follow lots of instructions from us. Then you need to be at a very commanding position when we face these kind of threats.
Can imagine how the situation would be at that point of time.
Yes.
It would be so back to back and so tight.
Yes.
Right. And you still had the patience to get out. How do you know that you're going to keep moving when you know you're not going to have, the certainty of actually getting out?
Yeah.
How did you feel?
So when we were landing, the Tripoli, we could see the bomb blowing off, and we landed in an airport. When we landed at this particular airport, we could see every best of best in aircraft in the industry, Boeings and Airbus. These aircrafts, they were just abandoned there. Entire airport was in a rundown condition. There were people sleeping inside the terminal. It was just like an open place. So normally what we do when we land in in any airport, we go to hospital to bring the patient. Here what happened, we couldn't enter the country because our insurance didn't support us.
Right.
So we had to wait at the airport. So we landed at the airport and we could sense that, things were pretty serious and it looked quite grim and so we were intimidating, in fact. So we were waiting for this patient to come and we just see one car full of people approaching at high speed. So have you ever seen a car with civilians coming to your aircraft? It
In
can
movies,
never
in
happen.
movies only, yeah.
In movies, yes,
Yeah.
probably, yeah. This was exactly like a movie scenario.
Right.
So you didn't anticipate that because as per protocol, no civilian cars can enter the
Airport.
tarmac, not just
Tarmac.
the
Oh, okay.
not just
It
the
was on the
airport. It was
tarmac.
on the tarmac.
Okay.
So they were literally like, you know, coming
That's
towards
how
the
bad the scenario was over
that's
there.
how bad and that's how unsecured the entire place was. You know, airports are the most secure places,
Yeah.
and that was the most unsecure place it looked like. And we didn't know what to anticipate. And when that car was charging at us, my flight nurse said she's going to turn on the locator, like, you know, GPS locator. We carry a device with that. I said, yes, go ahead. But in my mind, I knew that's the first thing they're going to take away from you. So, and the car stopped like a few 100 meters from us.
Okay.
And then it was a sedan. And probably some more than 10, 11 people get out of the sedan. They were dressed in all kinds of attire and knew this was a civilian car and people were coming towards us. We didn't know who they were. It could be anyone. So there's an aircraft, which safety matters because if that aircraft is not safe, we will never get out.
Right.
And there's a patient coming in, like, you know, as well in short, like in short span. And then if I don't think about the patient, like we can't just run away because the patient is also a responsibility now on his way. And the team, of course, the pilots and my flight nurse and all of us, like, you know, all of our safety was a big concern. So just held the breath, pray to God, and then just stood there thinking, what next? And there's nothing much you can do because, like, you know, they could have weapon. We don't carry weapons. So we just prayed and stood there crossing our fingers.
Yeah, that's how intense the situation was.
It was pretty intense. Yeah.
Let's go back. Mysore, JSS Medical College, post which you went to UK and Ireland for your post-graduation for your FCAI and MRCA. Most Indian doctors who go there and get such kind of qualifications mostly never return. What made you come back to India?
So my intention was always to return back to India, but to be with the family and in my country. Having said that, like, you know, I was I'd passed one of the most difficult exams in the world called fellowship in our anesthetics is one of the most difficult.
Is it?
Yeah, it's one of the toughest exams in the world.
Wow.
Because you have to study everything, like from radiology to anatomy to physiology to pathology. There's absolutely nothing you can't know about.
What's the prefix for that?
Fellowship in anesthetics.
Yeah.
Yeah. So that my FCAI.
FCAI. Okay, that is.
And MRCA
all
both.
right.
Like, you know,
Okay.
they are the toughest exams, and it's very hard to pass that exams. And once you pass that exams, and you are into a training post. So in the UK, when you go as a doctor, very few people get into training post. Most of the people, like, you know, they go there just to in a non-training post. That means they're kind of the career. There's no career progression. You earn. You make money, you can do anything you want, but there is no career progression. You can't become the top guy. But once you get when you're in training post and then you pass these exams, your life is set. Your career takes off roaring, like, you know. So it was a very comfortable life. Unlike India, we turn the tap on, you have water, just turn the switch,
Right.
roads are safe, education is safe, education is free, health is free as well, like, and then you earn very good amount. You don't have to come back. Yes, that was that was a very comfortable life setting, but it always haunted that.
This was back in which year?
In 2003 is when I went to UK.
Okay.
And then continued there till 2013. So we just, you know, we start we get into job, start our training, and we progress.
So 10 years you were in the UK.
I was in 10 years, I think. Yeah.
And you were in the training of anesthetic.
Yes. So I did my, I started as a junior doctor there and went into ICU critical care. That was my favorite, like, you know, specialty, and did my anesthetics and did all my exams. And then, like, you know, there were two instances. One is, of course, planning to come back as a long-term plan that may not be immediate. So one reason was coming back to be with the family. The second reason is when we look back, every minute, like every 4 minutes, there's a death on Indian road. And India needs this helicopter emergencies and air ambulance services more than any other country.
Right.
We have the youngest population here. 3% is the GDP loss to the country.
Largest population too, 1.4 billion today.
Yeah, youths. And then we have, with 3% is the GDP loss to the country. If a road is constructed at 2,500 crore, 25,000 crore is the estimated loss from deaths on the same roads. So, and again, looking back at these in terms of inter-hospital transfers, like between hospitals, and also pre-hospital emergency medicine. That is, before the patient comes to hospital on the roadside, it could be anywhere in farm, could be mountains, anywhere. So if you look at that, India is very behind, like literally 35 to 40 years behind in pre-hospital emergency and also transit care medicine. So looking at this, a huge gap and people dying, it was always, always at the back of your mind, why am I doing this in a country which has got a developed system? You should be rendering this service back home in India. So that's when, the thought was always there about returning back, but this was a right segment to pick and come back.
Right. FCAI, MRCA, two most elite medical fellowship programs. Is there any major difference? How did you feel when you cleared those two exams?
I cried. It's not the easiest exam to pass.
Right.
There were a lot of people from my own batch who were writing that exam. A lot of them failed that exam. And there were people who were localites as well. And they are in the system from birth, and they know how to crack these exams. But you passed that exam, and I got a distinction as well in intensive care. Like that, we have 4 modules in intensive care. I scored full marks, 4 out of 4. And when you come out, it is a relief, and it is like a life-changing moment, because this is one thing you dream, you eat, we live for years to get this exam. And when you do that and you come out and say you passed, and my professor, who was a lead examiner, and he's not supposed to examine me because they can do that, but they will be in charge of the examination. So he came and hugged me. That was a moment, getting a hug from the person who
Tears of joy.
Yeah, the tears of joy. Yes, I broke down. I cried
Someone
because that is a life-changing moment.
Right. Someone taking those two fellowship programs today, what would you tell them? One advice.
I always tell people who are taking these tough exams, it is one of the most difficult exam for a reason, because when you anesthetize a patient or you're looking after a critical patient, you're literally between sitting on a fine edge between life and death. One mistake of yours is zero room for any kind of an error. So you have to be the best in this to pass this exam. Never underestimate exam. No exam is worth taking twice. So when you are doing it, just do it, get it out of your way, give everything you have, eat, live, and sleep these exams, and just get this out of your way. Once you have it, then you're done. And you'll never forget what you study.
When did the idea of air ambulance come into your head? Because in 2017, this was barely a concept in India. What made you think this could be it? And why did you feel like India needs this?
Okay. So I was doing my fellowship exam courses. Like, we had to do millions of courses to get this exam. And we spent thousands of pounds.
That is FCAI,
Yeah,
MRCA.
the fellowship courses. So there are courses to go before we go for this exam. Well, we were doing these courses. I met my other director, Dr. Rahul. We had 2 founders of this company. We met in a course, and we were discussing about, I told him, I'm heading back to India. And few years ago, uncle had passed away as well. And we were discussing what India needs the most. And then we are looking at how India is struggling in terms of healthcare, and how we practice the best medicine in the UK. And when we in India, when we are the lot of condition, some of the ambulances turn up without oxygen. So that's when this idea kind of sprouted, and then culminated, and then took a shape and form of coming back to India to start a service exactly like we have in the UK. UK, we have helicopter emergency medical services, which is free of cost. there every citizen is covered under this, and people it's all clinical decision and clinical triaging that happens, who has to be airlifted. So looking at all this, we said we should bring a system like this in India, and we should save people. So that's where the idea started from.
Was the passing away of your uncle something that gave you an idea? Because if maybe he had been, you know, if he had reached the hospital a little earlier, he could have been saved.
More than little earlier, if the transfer had like right kind of team, trained medical team, because he had a brain bleed. It's, if he had a proper the training program, we have a training program now where we teach our doctors to transfer patients. So right equipments, right team, right speed, I think he would be with us today. And he was an extremely dynamic guy. He was the largest coffee exporter of India, and he didn't deserve to die at 60. 60 is very young, So, yes, and again, he was kind of a very big influence in my life. We saw the world through his eyes in terms of how he progressed, how he made it big, and how he literally ruled the world in terms of the coffee world. And it was very inspiring to be mentored by him, to be guided. And I was extremely close to him. He was he's a godfather and a father kind of a figure. So when I lost my uncle, and it really shook me, and it was not easy, especially when you're outside India and you lose some family member and you can't be with them in the last moments. It was very, very hard on me. And yes, that's a very big influence, because I'd experienced it. So it made it all more important to come back and do this.
Right. One was an emotional factor in terms of building the air ambulance or integrating or incorporating air ambulance service in India. One was an emotional factor into building air ambulance. What was the other factors that were actually strategically involved, and you think, you can make this happen?
Yeah. Of course, the emotional factor was there. And the second thing was my training. So we were trained to do this in India. We are in the UK, and part of the aeromedical services knew how this exactly works, how an organ gets airlifted, how a patient will be airlifted, what is a system, what kind of aircrafts we need. And also, if you look at Germany, it's a gold standard in helicopter emergencies or air ambulance world. They have one helicopter per million. So for 80 million population, they have 80 helicopters plus 20% backup. So that's like literally they have 100, 110 helicopters for a population of 80 million. And Germany is a small country, their flying time is 10 minutes, that's it. But
Right.
India, we have a huge topography, centralized tertiary care system, especially in 2016-17, we didn't have any district headquarters having the corporate hospital. Even today, not many district headquarters have a corporate hospital, but there are some medical college hospitals. Looking at all this, there was a huge gap in terms of patients getting the right care at the right time. And again, if you look at the Western world, you can't build a big hospital in every village. So entire world, the way that it operates is they have a centralized healthcare systems. So for example, London is a tertiary quaternary care center for entire that part of the London. It can be one hospital like that. So patients are brought into that hospitals by helicopters. So you can't build infrastructure everywhere.
Right.
So patients, they need to be airlifted here, but by a right team with the right speed. So looking at this entire vacuum in the industry in terms of saving lives, we said this is the right thing, and we should work with the government to bring a system like in the UK where every citizen, no one should be left behind.
You were inspired by the system in UK. Did anyone tell you this is a bad idea in India?
Absolutely. So when we came back, we met a lot of people, and they first no one could understand this concept. I know we worked with a very big market research agency as well to make them understand the difference between a primary transfer and a secondary transfer. It took us 6 months. And a lot of people said, like, it's a very restricted field, lot of regulatory authorities are there. Number one. Number two, like finance, like, who's going to pay for this? Why would government is more interested in killing mosquitoes, preventing malaria. No one will think about, supporting a system like this. And as I said, like regulations were also very, very tight on this. DGCA did not even have a document on how to do a helicopter emergency when we came back. So when this CAR document was drafted, the civil aviation requirement document was drafted, we were the only non-OEMs invited to give our inputs into this. So like they were all people from Bell Helicopters, Augusta, Eurocopter. And imagine, like we were not helicopter manufacturers, but they took our input. And we changed a lot of things in that draft as well. Like, when they said only twin engine should be used for airlifting patients, we said no, even single engine should be allowed because they're equally safe. But at the same time, like we can make this affordable service. So there were categories of helicopter emergencies, and then we give a lot of input in getting that, finalizing that CAR document. That's where we started, where even the regulation didn't exist from the DGCA at that time.
Where did how was year one of ICAT? Tell me the reality, not the vision.
Yeah. So the reality, no one knew us. Literally, we had to meet every hospital and sensitize them. Look, we are planning to start an air ambulance service. We did a lot of aeromedical workshop. We did our first aeromedical workshop in Society of Emergency Medicine India, MCON conference. That's an international conference on emergency medicine. We did a drill how a patient could be rescued. We sensitized the medical industry first, and then we started simultaneously speaking to the aviation people where we can start start these operations. And a lot of people didn't believe this can happen in India. Literally 90% of the organs used to go waste because there was no connection between the hospitals, the aviation, and the families. So we took that up as well. We started writing the guidelines. We started writing the SOPs, and then we put it across to the hospitals. And again, that comes to the execution part or even operational part. Finance, it was hard. We didn't come here with any investors.
Right.
We didn't take money from anyone. We didn't sell a dream. We said, like, we'll live this and make proof of concept. Like the first thing is going to be proof of concept. So worked 1 week in UK, 3 weeks in India. So whatever 1 week working in the UK was 24/7 work. So it's a 24/7. We work all 7 days without a break.
Okay.
So that whatever the money earned there came and poured in here to build the entire thing. From buying the equipments, speaking to the aircraft owners and the hospitals as well.
Were there moments early on where you thought, shit, I made a mistake?
I think I wouldn't say I made a mistake, but I used to really miss my ICU work because it's very rewarding when you work in ICU. At the same time, we were building something so big. There was no looking back. There was no time for regret. And there's so much to do. And no, never thought it was a mistake, but there were moments when you thought, I had a comfortable job back in the UK. I had a home, everything was so set there. Is it worth taking all this? But again, never regretted it. Of course, it's human to think is it worth all these problems and, denials and people putting you down? But then always, every single day was taken as a victory. So today we did something that was a victory and celebrated that. So every single day was a celebration in terms of something positive we achieved. That's how this was built.
Like they say, growth happens when you face discomfort.
Absolutely.
Right.
Yeah.
So you took emergency medicine and saving time and merged it into one. Is that how you can define ICAT?
Yes. So it is. It's an integration of highly, I would say, very critical patients in a time-sensitive manner.
Right.
Both are very unforgiving specialties: critical care medicine and emergency medicine and aviation. So you can't make any mistake, because, as I said, they both are very unforgiving. Integrating these two, a highly sensitive field, as is a very challenging job. Yes, you're right in saying that. Yes, we merge these into.
these two together. Walk me through how a mission into a conflict zone works, from the time you get the call to the time you're airborne.
Okay. Let me talk about Karachi.
Yeah.
Right. Okay. So people call me like, Pakistan returned. So because I went to, in India, they say US returned, UK returned. So kind of I'm a Pakistan
Not a
returned.
pleasant thing to hear.
No, it's all right. Like it's
In profession,
different. Yeah.
yes.
We have a lot of people who are returned from everywhere, but not
From
many people who are
Pakistan.
Pakistan returned. So this was we got a call from this family, and also hospital transplant team, organ transplant, lung transplant team, Dr. Paul Ramesh, Chennai Apollo Hospital. And they received a call that there's a patient with a severe lung disease who requires who needs a lung transplant. So, and the family rang us because the hospital had shared our number, and a brother who's the patient's brother called me and said, I need to bring my sister from Karachi to Chennai for lung transplant. It was, and I know first it is the aviation logistics has to be taken, and we had to take permissions from Pakistan authorities. We are flying over sensitive zones, and then all those aviation team took care of that. And second one was the mission on terms of patient management. So we need to make a detailed management on this patient because she had a severe lung disease. They're so brittle that in minute things can change. You take oxygen is disconnected from the UN for half a second, they can just saturations can go down and things can get into as bad spiral you get into. So we planned the entire journey, how we are going to do, what time we land, what time the patient should come to the airport. Again, we didn't get insurance to go to hospital. We enter the country because when you're in airport, it's an international zone. You don't need a passport, stamping, anything. We are part of the crew, but if you have to leave the airport, then you need permission to enter the country, and there's a different insurance. Very, very rarely we get denied in going into country because we only do bed-to-bed transfers. We always take over the patient from bedside and then bring to the hospital bedside and hand over. We never take over the tarmac because patients can come in really bad condition, and then it's very difficult to stabilize them inside an airport. We rather stabilize them in the hospital when we take over the patient. So, but here we didn't have that luxury of entering the country. So we were at the airport. We landed after all the planning and permissions. We landed in Karachi airport. First thing, as you expect, we were surrounded. We were surrounded by the Pakistan military guys who are manning that aircraft. It's an Indian registration aircraft, and then they know, they know it's an air ambulance coming, landing. We get a priority landing, but still, end of the day, you always they always will kind of look at you. So we landed, and they had their guns and everything. So we got out and we explained to them, we are the doctors, we are medical team, and then we come here to take a patient. And they knew they were expecting, but still it is a kind of it's very, very important to have a rapport because you do not want to be on the wrong side. So, and then we were expecting this patient to come. We were all waiting, you want to do when you're in Pakistan, you just want to get out of the country and bring the patient back safe. End of the day, patient might be anyone. They are Pakistani or whatever nation, they are patient first. Even when we treat criminals or anyone for that matter, we look at them as patient first. Everything
Absolutely.
is secondary. So we were waiting for her, and then she comes, and she was quite sick, a lot of oxygen, and we just wanted to take off and leave, stabilize her. We hear that she's forgotten a passport at home, and it is getting dark, duskier a bit, getting towards evening, because again, nighttime flying, can become a little challenging. So because we fly on smaller aircrafts, 7-seater aircrafts, so we always want the weather to be in prime condition when we fly out. Right. So we had to wait for another hour for brother to go get the passport back. And then we got the passport back and we flew, landed in Chennai, and then switched her over to all the land ambulance thing and went to the hospital and handed over. This happened like literally a night before surgical strikes. So, like, once we came back and we realized the next thing surgical strike happened, it literally, it shakes you. Like, it could have been few.
Was this your first?
First trip to Pakistan.
No. Was this your first task as strike captain?
No, it's not like it. We had done few by then. So this is how, like, and then we had to take her back as well. So she came. I think there was a huge problem. Like, she wanted to get back after a few days, so we had to take her back and drop her and come. And again, that was post-surgical strike, so it was more. Things were not very friendly after the surgical strike. So anyway, we completed the mission very successfully. We brought her in and took her back as well. So this is exactly how this entire thing works. Yeah,
Right.
entering the conflict zone is not always pleasant, but it's always challenging, and it's adrenaline rush. Yeah. So sometimes people say, like, you guys are adrenaline junkies. Yes, probably. Yes, maybe takes a kind of personality to do
Right.
this.
Exactly.
Yeah.
You have no military protection when you land in these places. What is your actual safety when you land in places like Kabul?
We have to just trust in the system. And I'll tell you about Chhattisgarh, which is much more recent and relevant. So during elections in Chhattisgarh, both during assembly and general elections, we were asked by the election commissioner to be there. And we were there in Bastar, that is Jagdalpur Airport. So Jagdalpur Airport is India's second most sensitive airport. We were covering the election officers and the CRPF. So we put an aircraft, like a helicopter and a fixed wing plane, at Jagdalpur Airport, and then we were on standby inside the airport for any injuries inside any of the jungles around that region. If you if you're seeing Chhattisgarh, they're very thick jungles, and that's where all the Naxalite activity happen. And so we were responding by helicopter into these thick jungles onto a sanitized helipads. Of course, then helipads are sanitized, true for landmines, but they could be always cross-firing. So we were responding there and landing into these airports, helipads like Narayanpur, Bijapur, Sukma, and places like this, and retrieving these CRPF people who had like gunshot injuries, landmine, IED blast, AK-47 going through liver to lungs. We get a call, we immediately take off because pilots, all the medical team, we were there leading this entire operation. We take off, go into the jungles, get the CRPF guys, whoever it is, stabilize them on board, and then bring them to Jagdalpur or fly them to Raipur or Delhi, depending on their criticalities. So when we were even after the mission, like, people asked us, like, don't wear your uniforms, don't be branded, like, they don't harm healthcare workers, but we are working opposite them. So it was a bit intimidating, because even a corporate there carries a bodyguard, has a bodyguard with proper guns. So even when we sat down for dinner, I used to ask my team, like, let's not all of us go to dinner at once. Like, half of you stay in the room, because if they come and attack, like, at least half of us will be saved. We don't get any kind of a military protections, but when we go into airports, they always the aircraft safety is takes a priority when we land. But again, like, anything can happen anywhere.
Right.
Yes. So
has there ever been a patient you couldn't get out, not because of medicine, but because the situation on the ground was unstable?
Yeah. More than on the ground, I would say the numbers. So it was during COVID. We used to get, like, what is a phone log, like, in iPhone, some hundreds or 200. if I get a call now, before I could get to the second call, my logs would be done. You can't even go back and see who called you. That was number of calls, like literally more than 200 calls in 15-20 minutes. Patients begging to be airlifted because of this either lack of oxygen, or they want to come to a higher care center. We had like even judges, ministers, MPs lining up, and richest of rich Indians. I don't want to name them because it's a patient confidentiality. And we used to like rescue. We had 5 aircrafts. We were putting everyone on lung bypass, ECMO, and then we're bringing them to higher care centers. But we are limited by capacity. We had only 5 planes. I can't bring like 500 planes and do these transfers. The ones we saved, didn't there was absolutely zero happy feeling about the patients we saved. The one that used to haunt me the most were the ones we left behind, and they
Why was
died.
there no happy feeling?
Because if we saved one, there were 200 dying. And then those 20 people or 200 people, family speaking to me, like, saying that we were waiting, didn't come. That would haunt me so much. That noise of people calling and asking for airlifting, and where we couldn't execute because we had shortage of planes.
You didn't have inventory. No inventory.
Yeah, no inventory. And that painful phone calls which I heard over and over and over again, 24/7. It's like for just 2 hours. Those calls, after that, after COVID, I still don't listen to music because any noise is like a trauma to me. So my car never turn the music on.
Really?
Absolutely, yeah. My car is it's like cold.
I'm never
stone.
traveling with you.
Yeah, I know. No one more likes to travel with me. It is freezing and it is silent. So yeah.
Right.
Those were the ones. But again, if you just ask me about the logistic thing, there are certain countries where we can, like for now, we can't go to Iran. But so far, we haven't had any case that, okay, we didn't go because there's no permission. We get through any situation. We can go to Kabul, we can go into Karachi. I've landed in Mauritania. Mauritania,
Okay.
in Africa. So, you should see the hospital facilities there. They are all rundown buildings, live wire hanging on you, and you to get in, and then they're like absolutely any small deviation from what they think is right, not what is right, what they think is right. For example, you take your mobile out to make a call, that's it, they'll just shoot you. So been into those places as well. So it is just that as long as we have insurance, we go into any country. There's no restriction. There's no conflict zone that has ever said like I
Right.
can't go. As long as we get a permission, we'll go.
We've operated in Afghanistan, Pakistan, Israel, Egypt. Is there a mission that still keeps you up at night? Which mission do you think about the most? The one you simply cannot forget?
Of course, there are two transfers which I can talk about. One is conflict zone transfers, you're asking me particularly. That was the Israel mission. So there was this lady who had gone there for treatment, and we are bringing. It was almost like an intuition. At the speed at which we worked. So she was the plane. Medical team landed from Hyderabad to Bangalore because the plane was in Bangalore. And once the team landed here, they were going to Israeli embassy to get their passport stamped, because Israeli, we have a High Commission office here, and they are very, very helpful in terms of the visas and things. We have a very personal relationship with all the embassies. So we were sending the team there for the stamping and things like that. And this aircraft, which was in Bangalore, which was supposed to take off, developed a crack on a windshield or something. We immediately had to turn the team to the second aircraft, which was a standby aircraft, which was in Goa. So we had to send the team to Goa, and we had absolutely no time because the team has to get the stamping done, come to airport, then go to Goa, and the departure was planned. mean, we had a choice of postponing that flight by 1 day, but patient was pretty critical, and we said like, no, we'll just get this done. It was not like very, very critical, but yeah, but as soon the better. But I think it is something else which was telling us like, just get this done today. So we sent the equipments in the morning by a different team, so that this time will not be delayed, so they can just board and take off and leave. And from when they left the embassy inside the airport, we spoke to every official there to get them into the airport as soon as possible, because they're taking a commercial flight to Goa. And the speed at which we did without missing a single minute, because this team would have lost they would have missed that flight. With all the officers and everyone cooperating, we got them in, boarded them, and the equipments had already reached in the morning we were taken by a different team. And we took off and went to Tel Aviv. We brought this patient on the aircraft. We took off. Plane had just crossed Dubai. They just crossed Dubai, and they took a halt in Dubai to fuel. That's when Tel Aviv was attacked. So we escaped the entire thing by 2 hours. That was the closest. I mean, rest were all like predictable. We knew something's not right. When these unpredictable things
Who
happen.
attacked Tel Aviv?
Hamas. Yeah,
Okay.
that it's a couple of years ago.
Right.
So yeah, that was absolutely no way of escaping that, because they
Yeah.
attacked
They
the entire
ambushed the entire
city
city.
was
Right.
yes, and so that still wakes me up at night thinking like, what a narrow escape it was, like the entire crew, patient, family. So yeah, when it is unpredictable is what scares you. If it's predictable, you're prepared at least to go face tackle. You have you run the entire thing in your mind, all the protocols and guidelines, what you should do, how to perform under pressure and things like that. And uh, we'll be always constantly in touch with the team and make sure everything is fine, and sensitize as many officers possible there, including like, we have to get some help from the local Indian High Commissioner's office and ambassadors, whatever it takes. We always keep all our grounds covered for safety. But here it is a bit tough when you don't know, like, you're going to face a challenge like this. Yeah.
There's another moment from your trailer where there's a civilian car coming straight at you, full speed, racing straight towards the aircraft on the runway. Tell me exactly what happened.
So we were expecting the patient to come, and we were all waiting near the aircraft. It was a pretty hairy moment, because we were waiting patient to come. We saw that it was totally unsecured airport, and there was like, it was a conflict zone, and we had already seen a bomb. And so when this civilian car started approaching us straight onto the aircraft, like not even entering the airport, just literally coming into the tarmac, and we had a plane and the team there. It was scary. It was really scary. Like, what next? Who are these people? Why are they coming towards us? Are they going to attack us? Are they going to like abduct us? Are they going to hijack the plane? I mean, every single thing run in your mind. Like, how are we going to deal with this? So again, like, everyone froze that minute, looking at this entire. This sedan coming towards us. Not only coming, it just stopped few yards from us, and then number of people got out of that car. People entering the airport, you always have some kind of you see at least the people coming into airport are a little dressed, well dressed.
Libya.
It's in Libya, yeah. They're well dressed, and you can make out, like, but people who came out, it was really scary. Like, they were just in, I don't know, they were wearing everything possible, all kind of clothes, and you knew that moment, like, these are not passengers. Or, there were no operations there. There were no commercial planes, so definitely not passengers. Who are they? Like, why are they coming into the aircraft? So that moment is when we turned on the locators, and then, although you knew they're not going to be of much use after once they attack you, I think that was really, really scary. And as I said, like, you can't freeze. You have to keep your cool and guide the team and make sure that we don't panic. And there's nothing much you can do. You can't, aircraft is not something which you can turn on like a car, like a bike and zoom off. It takes its own time, and we need to get the clearances to take off and things like that. We have to follow the aviation safety protocols. So it wasn't easy, but yes, luckily they turned out to be family members who came to see that patient off.
They were family members.
Yes.
Oh.
Yeah, but until we spoke to them, we didn't know who they were. I mean, we couldn't speak actually, because after they just stood there looking at us, and then we were expecting an ambulance to come. No ambulance comes. Then there's another 4x5 or 4 which comes with a patient, which didn't have any ambulance sign on that, no lights, nothing. Just another car comes really close to us because now the patient's on board. Since those people just stood there, we assumed they could be family members or relatives or friends because they didn't come close to us. Then this car comes after 15 minutes with the patient, which came even much more closer. Literally, it came straight beside us and stood. And again, until we came to know there's a patient inside that, we didn't know who they were. So twice we faced that in a span of like 30 minutes.
Most people don't know what is ECMO. Can you please explain that in simple terms?
Yeah.
And it's also all the more extraordinary to perform ECMO in a moving aircraft. So can you please tell me about that?
So ECMO stands for extracorporeal membrane oxygenation. That means like you're literally oxygenation is you're getting oxygen into the body by either creating a lung or a heart or both outside body. So we put on a machine which performs like a lung outside the body. Extra means outside, corpus means body, outside the body. Or I'll just give you an example. Probably that will kind of a
Yes.
patient transfer, which if I explain, you'll understand how it works. So there was this guy, like, doctor, a 45-year-old. He's very popular as well, wildlife doctor. And he was trying to tranquilize an elephant in Shimoga, which is, 300 kilometers from Bangalore. And that particular elephant had killed 2 college students. So there were huge pressure from public and administration, district administration, to tranquilize and capture this elephant so it could be tamed and left back into the forest. So as a wildlife doctor in charge of that particular forest, he was kind of he rushed into this mission because he came to know that elephant is spotted. When he when he went into the forest and he was trying to load his gun up, gun's pretty heavy, gun with tranquilizers, that is to sedative medications. This elephant was right behind the bush, just charged and came, and he stamped on his chest. I mean, you can imagine elephant's legs on our chest, it could crush everything.
Absolutely.
And he was taken to a hospital in Shimoga, and he was stabilized there in Nanjappa hospital. And then we got a call to bring him to Manipal for further treatment. Now the call was with us, how we transfer this patient, because his lungs were so damaged, we didn't know if we move, what's going to happen. He was like,
Very fragile state.
very, very, very super fragile. And so we made a bold decision of putting on ECMO, like, this lung bypass. So lung outside the body, this is what ECMO is. So his lungs will be fully rested, and this ECMO will become a lung outside his body. This will perform like lung. So it is bypassing the lung.
Oh, wow.
So we can bypass the heart. I'll tell you about the heart thing.
Mhm.
So this lung. So we put this ECMO on him. This is India's first trauma ECMO. In a trauma where ECMO has been initiated. Now, the ECMO is done for lung diseases and COVID pathologies, and where the lung is fully
Collapse.
destroyed and ventilators do not work. That's when the ECMO comes into place. And again, like, putting it on a patient who are, like, on a trauma, because ECMO itself, it use a medication to keep the blood thin, that's called anticoagulant, that can make his lung bleed more as well. So, but that was the only way that's the right way to do it. Again, so it's very risky as well. So we put him on the ECMO and we brought him to Bangalore, creating a 5-district corridor. So 8 IPS officers involved. So that was a transfer. Like, that's how.
He wasn't airlifted.
No. Shimoga Airport was inaugurated by Prime Minister, but it was not operational. So all the ATC, ADC, all the staff, they were all sitting in Mangalore. To mobilize them, it was taking 48 hours. So we didn't have that kind of a time. We decided we'll bring him by road. So Shimoga to here, I think, 6 hours by road. We brought him in 238 minutes, so less than 4 hours. Because the entire road between Shimoga, Nanjappa Hospital to Manipur Hospital, the road was emptied. It's called a green corridor.
Green corridor.
Yeah, green corridors created with a full police convoy. We rushed, and as I said, like less than 4 hours, we brought him to the hospital door, not just entering Bangalore. Thanks to a lot of IPS officers who coordinated, from the SP, Mr. Mithun in Shumaga, till Mr. Anuchit, who was the Joint Commissioner Traffic that time in Bangalore. Like literally they all coordinated with each other, and then we brought him here. And we walked back home after 52 days. Even yesterday I was speaking to Shruti's wife. So a lot of families keep in touch with us. Yeah.
That's a great achievement.
It is like, it's very rewarding more than an achievement. Like you feel, okay, all this, all your hard work is exhausted, the risk you
When you
take.
save someone, I'm getting goosebumps now.
I know, I understand that, yeah.
365 patients on ECMO. You had no other options. Can you please explain that?
No other options in terms of
Like people who had zero other options.
okay, yeah. Yes, ECMO is ultra critical care. So that is the highest form of support you can give it to a patient. They achieve these kind of numbers. It'll take, for any air ambulance, it takes tens of years. Like, we don't even know 10, 15 years when they can achieve a number like this. We work like 24/7 on this. We have a dedicated ECMO team. We have all the circuits, disposables stocked in the office. Our response time is 2 hours in terms of I was sitting at a program and get a call at 5:30 that there's a patient in Gulbarga who had a cardiac arrest. So this is about heart ECMO. That was a lung ECMO. We didn't know anything about this person. He was in his mid-50s, and then I kind of walk out of that program because it was like he had a cardiac, his heart had stopped. They were doing CPR. It was Gulbarga, and call came at 5:30, and the airport, Gulbarga airport closes at 5:30 p.m. So how do we get there? And I had no clue who this guy was. So we immediately, team was mobilized from our bases in Yelahanka to the airport. So we took a commercial plane, that is an Indigo, to Gulbarga. Sorry, not to Gulbarga. Gulbarga airport was shut. And we had to fly to Hyderabad. From Hyderabad, drive down to Gulbarga. By then, he had arrested some almost 12 times. So his heart was stopping. They were doing a CPR. He was a young guy who met with an accident while he was traveling, and they fixed he had a fracture in his arm. They fixed the fracture, and after surgery, his heart stopped. So he was very, very unstable. I mean, of course, more than unstable. It was literally, heart stops means you're dead. There were some condolence messages going around saying that he's dead, and we came to know that point that he is a chairman for a board and he was a very prominent political figure. However, when we mobilized the team and all, we didn't know much. So we then drew down to Gulbarga 2 a.m. We put him on the heart bypass. So we created a heart outside his body, which will do all the heart functions. And we airlifted him to Manipal. This happened in November, around November time. And
Last year?
No, I think 3 years ago.
Okay.
And Jan 26, he went back to office and hoisted the flag. So from being like almost dead to going back to work full-fledged. So this is building a system or building this eco team and protocols and procedures. I don't think so any other air ambulance across the world has achieved a number like this in such a short span of
coming
time.
to that.
Yeah.
You did India's first international ECMO transfer, Doha to Chennai in 2015. What was the reaction from the medical team, from the medical world, when you said you were going to do this?
Yes. So this was like a very interesting case. this patient was in Doha and he was a Pakistani citizen.
Pakistani
He is a
citizen.
Pakistani citizen. So we had challenges in terms of first a medical challenge, because bringing a patient on ECMO is not a joke. Second thing is international transfer. It's not just a domestic. We can have a lot of support within India. We can do that. Number three, he was a Pakistani citizen. So once we enter India, we didn't know what problems we were going to face at the airport, although he was granted Indian visa. And so all these three challenges put together, an international transfer of a Pakistani patient and on ECMO. So, and the first time ever in India. Every single minute was a challenge. I might have spoken to the CISF in Chennai airport and the immigration officers. I might have spoken to them some 200 times for nearly for 4 days. There's a Pakistan patient. He's on this ECMO machine. You can't stop him on immigration. You have to go on board, do his immigration clearance, and let us take him to the hospital in Chennai. You can't hold us back. His guy will die if you're going to delay him getting out of the aircraft and going in. And then, the entire logistics and the complexity and the nationality, everything put together. I don't think so, like many would believe, this could be done. But when we did it, it was published and it was, we were presented in the conference called SWAC. It is one of the topmost ECMO conference in the world. In Doha, we presented. It was published in the Qatar Medical Journal. This was spoken about, even today, people, how did you bypass and or surpass every single challenge that. But again, when we landed in Chennai, because of his nationality, we did get stuck. We got stuck we were supposed to be there for 30 minutes max to max, but we got stuck for 1.5 hours. In spite of sensitizing them for 2 to 3 days, we did just we knew this was going to happen, but luckily, thank God, everything went well and we took him to hospital safely.
Your longest transfer, Lucknow to Philadelphia, 21,000 kilometers, 30 hours, 7 countries. What was happening medically inside of the aircraft? Could you please explain?
Yeah, so we did one from Portland to Chennai. That was the longest aeromedical retrieval until recently. We did this Lucknow to Philadelphia. And that patient had multi-organ failure, and it was covered by BBC. It was covered by every international newspaper, this transfer, because one of the longest aeromedical retrievals. And then, but recently we broke that record by taking a patient from Lucknow to Philadelphia on a heart bypass machine, on a VA ECMO. So again, ECMOs, people have seen in the Western world where the system is a bit established, that they take few hours, maybe 2-3 hours max, and they transfer the patient. And taking an ECMO patient from a hospital ICU to a CT scanner is a nightmare within the hospital.
ICU to
CT scanner itself is a huge, it's a biggest nightmare for any doctor, working in intensive care, because the entire ECMO machine, the patient, all the circuits and million lines and monitors have to go along with the patient into the CT scanner. That itself isn't. But we took this patient all the way from Lucknow to Philadelphia. We have to monitor a lot of parameters when we are going, but our strength is medical team and the equipments we carry and the training the team has. So we had a very fully trained team, and we carry even our blood gas machine, which can give a lot of readings. It is almost taking a portable laboratory with you. So we take all the equipments for laboratory equipments. We carry around 150 kilo equipments with us. And since we were confident about our team, equipment, and of course the patient was super critical, and we have a family member on board as well, and all the all of them were from medical fraternity. So yes, it was a very challenging transfer. I think the training and the protocols and the checklist and guidelines what we follow is what is very important when we do these transfers.
How many transits did you take?
We took 4 hops, 4 tech halts. Yeah, so one will be in Abu Dhabi, then in Turkey, then in Shannon, and then into Philadelphia.
Most people know ICAT Air Ambulance, but you've also built ICAT Gulf, ICAT USA, ICAT Maldives, ICAT Response Plus, FEM Education, FAM Education, the ICAT Foundation. How does one person build all of this?
So it was more than like, it was a necessity. The gap, it could be geographical strategy, starting the operations, for example. When we started ICAT Maldives, we knew they have 950 inhabited islands and the patients have to be airlifted to Male. So they required a system and a lot of resorts as well, not only islands and local Maldivians, but there are a lot of people coming as tourists. When there is a medical emergency, they need a system. So that's where ICAT Maldives came into picture. ICAT Gulf and ICAT Response Plus Medical, they both are based out of UAE. And we do a lot of work for Department of Health, taking patients from Abu Dhabi to USA for treatment. It is for the, they recognize our strength in medical field, our expertise in aeromedical transfers, and that's the reason why ICAT, we have a JV with the Response Plus Medical there with ICAT, and ICAT Response came into picture. ICAT USA, again, the need of a lot of, as I was entering here, I was just speaking to a patient who's in Pennsylvania, wants to return back to India. Mother came to visit. She fell, broke ankle, fractured. They had to be brought back to India because once you have any kind of injury or a medical emergency, people don't want to stay outside the country. They want to come back here to their own doctors. And the third thing, the third one is that's ICAT USA FAM Education. So this is pre-hospital education, and FAM is a fellowship in neuromedical sciences, where we train. Again, this was a gap to fill in the gap of like having trained medical personnel. So we created a training program, which is a 1-year training program. We train doctors and paramedics in this training program. We call them aeromedical commandos. They train from primary assessment up to cut open a chest in 6 minutes if there is a gunshot wound into heart and heart is bleeding. They can do cesarean section roadside. And all these candidates are trained by the faculty from the UK. And we fly them all to UK and get them trained there as well. We use real helicopters and planes to train these candidates. And that is a FAM education in the FAM course, which is accredited by JSS University, and it is certified by KSS HAMS in the UK. Moving on, ICAT Foundation. Again, ICAT Foundation, when we did the Kerala operation in 2018, we airlifted patients free of cost from all the relief camps. And there were requests for people to start a foundation so they can donate into us to do this good work. Then ICAT Foundation was established. Incidentally, COVID happened. In COVID, we ran multiple initiatives. One of the biggest is COVID India campaign under the aegis of ICAT Foundation. So that we did some phenomenal work there, including the world record CPR. Everything is done under ICAT Foundation, which is our philanthropic organization. We support children organ airlifting and things like that through that foundation as well. So these are I think most of them complement with each other, and they were all established because there was a need for that, and we had to get into the zone. And ICAT USA is helping a lot of Indian diaspora to be brought back home. Again, we are expanding into Europe as well, which is going to be called ICAT Europe, and very soon we'll be in Saudi. So we are getting into different zones.
Just to get into the business side of things, is this a franchisee?
No, we're not a franchisee. We don't have any outside investors.
Okay.
ICAT Maldives is we have 2 partners there along with ICAT. ICAT has got 2 partners there. So 50% is owned by ICAT, 50% is owned by Maldivian company.
Okay.
ICAT Response is a JV between Response Plus Medical. They have around 400 ambulances, land ambulances, and ICAT India is 50% JV. ICAT, the primary ICAT India is fully owned by us. Okay. So I have absolutely no outside investors so far, not a franchise.
Completely bootstrapped.
Completely bootstrapped.
But who are getting backing from the government?
No, it's government projects. When we do, we don't get a backing. We get when we Chhattisgarh operations, when we did Madhya Pradesh, we ran a pilot program for the entire year. airlifting patients free of cost across Madhya Pradesh using a helicopter and a plane. We were responding to remotest villages, airlifting patients like bleeding mother or gunshot, policeman shot by a local gunda. Tracker ran over a tractor, which ran over a farmer who was ran over by a tractor. So we responded and we airlifted patients. So first, free helicopter services of India. Again, or air ambulance service of India. So government funds the activity, but and there's nothing called government support in terms of any regulation, anything like that. Yeah,
It's not an NGO, right?
it's not an NGO.
NGO.
So ICAT Foundation is an NGO.
NGO, only
Yeah.
the foundation.
ICAT Health or ICAT India is a private limited.
Got it.
All of them, either they're LLP or LIC. LLC. US it's LLC. We call it LLC.
Right. Okay.
And then in Maldives, it's a private limited. And here in Gulf, one is they're both LLPs and a JVs. Yeah.
So LLP
It's a
LLC,
partnership company or
Okay.
a corporation.
Got it.
But none of them are other than ICAT Foundation. That's the only one which is a
Understood.
philanthropic one.
Perfect. Got
Yeah,
it.
yeah.
Can you please mention the key difference between FEM education and FAM education?
The FEM education is pre-hospital emergency medical. FAM is Fellowship in Neuromedical Sciences.
Okay.
So the FAM happens under FEM. Under FEM, we can do anything to do with the pre-hospital. So we can train doctors, paramedics. We are coming up with a new course for the Public Health Foundation to train all their top doctors, like they could be district health officers, medical superintendents, directors, to give a 1-year training program where we train them about natural disasters and national disasters, and also how to use air ambulances. In that one of the integrated part is air ambulance. So any activity to do with the pre-hospital happens through FEM.
Coming to NODAC, the National Organ Donation Awareness Campaign. You're the campaign head. What is the state of organ donation in India right now, and how bad is the gap?
Huge gap between the demand and supply. There's a huge gap. More than 90% of the patients who are registered to receive an organ die before they get an organ. So that is a gap. And if you look at the Indian map, only southern Indian states are the transplant hubs, because the organ donations only happening in southern Indian states like Telangana, Karnataka, Tamil Nadu. And these are the only places, and some parts in Gujarat, where the organ donation happen. It's just a culture thing. Entire northern part of India, hardly any organ donation happen. But people who require organ, it could be a lung, it could be heart, it could be kidney, it could be liver. Patients are just waiting on the waiting list. As I said, 90% of the time, 90% of them die before they get the organ. So you can imagine the gap there. Yeah, go ahead.
Yeah, I spoke about organ donation.
Yeah.
I've also heard India is a big marketplace for organ trafficking.
Yeah.
Is that true?
No, I don't know, probably in the past, but now it's such a transparent system, and everything is online, because there are national registries, NOTO, then there are state registries, and allocation happens in a very transparent manner. Anyone can see which organ has come available, where is a donor, which hospital they're getting into, how the hospitals are allocated on, it goes around turns or a patient's criticality, the decision happens, the matching, everything is very transparent. Absolutely, I don't believe there is an organ black market at all in India anymore.
Nothing happening.
There's nothing like that, because and the regulations are very strict. If there is a kind of a misconduct or a malpractice in a hospital, the CEO directly goes to jail. So that's how strict the organ world has become. So absolutely no room for any malpractices now.
You hold 2 World Book of Records. One for training 28,762 students in CPR in a single given day. another for training 2,000 Karnataka police officers in CPR in a single given day. How does something like this logically even happen?
Yeah, I think this is a mind-blowing number for
It is.
anyone to
I
think
had to
of.
look at the screen
Yeah,
to
twice.
get the number twice.
So, when did the first world record, a lot of planning, logistics, 3 months of planning happened to create that world record. On a weekend, we trained because we need thousands of trainers to train these 28,000. It's not like 3 people, 4 people. We got a very good support from Chittadurga. We did this in Chittadurga during Sharana Samskriti Utsava.
Okay.
And Mr. Naveen,
With Naveen Kotti.
yes, he gave a huge support from the Durga side. We had 1,000 mannequins with us, which came like literally like a blessing from American Heart Association. They donated 1,000 mannequins to us. And again, I can talk the entire day about this, how we did this world record. And these 1,000 mannequins were used to train the training of the trainers of the weekend, where we train doctors, nurses, dental students, people like them to training of trainers. And then we went to 200 locations at once, where the buses were organized to go into these locations. Within 8 hours, we trained 28,000 people, mostly the colleges on the high school. And that was during Dasara, and the exams were going on right before Dasara. So there was a white paper from the education officer to stop the exam for 3 hours to facilitate this CPR training. But again, like, this is not just a record of like longest hair or longest nail. This is a life-saving skill which
Right.
we taught, and it is a very, very proud number. The second one, training Karnataka police, again in Kantirava Stadium, men in uniform to be trained within 2 hours. In 2 hours, we trained 2,000 plus policemen. The strength is our trainers, and all our trainers are topmost emergency or ICU doctors. So we don't train them through paramedics and things like that. So, including our Honorable Health Minister, Dinesh Gundu who was then serving, and Dayanand ji was a police commissioner, they personally took the training along with the policeman. There's a huge motivating factor for everyone. And also it highlights the importance, and it created a world record again.
Right. You spoke about CPR. We
Yeah.
spoke about CPR.
Yeah.
It's a skill. It's a life-saving
Yeah.
skill. Can you talk 2 minutes about why every human being should know how to perform CPR irrespective of their profession?
So, CPR is an essential skill. If you look at Prague, 99% of the population there who are above 11 years are trained in CPR.
Right.
At least 90% of the population. If you look at the Western world, it is 30 to 40% are trained in. So there's a room of 100 people, 40 people are trained in CPR. In India, in Bangalore, which is supposed to be the Silicon City of less than 0.05, not even 0.01% of people are trained in CPR. So if you find people of 100 people, not even half of them are trained in CPR. That is the condition at this point of time. So these out of hospital cardiac arrest, that where CPR is performed when cardiac arrest happen, like how KK was performing on stage, our Abdul Kalam ji was addressing on stage, and it just collapsed, and CPR was what required to save him. So this cardiac arrest can happen anywhere. It can happen in your at your house, or at a police station, or it could happen in railway station, bus stand, toilet. We trained the entire BGC, all the caddies, all the staff members, from the cleaners are trained in CPR there. So we trained the entire club. Every 2 years we train them there. So if this is a significance. Like anyone from a child to the oldest man can have a cardiac arrest, and 80% of them always happen outside hospital. They don't happen inside the hospital. So we need this training program. It's a very essential skill, and India again, we are very behind in this. We have to, it's a huge effort, and we are trying our best to train as many as possible. Recently, we trained a few weeks ago, Gorkha Regiment, Southern Command. All of them, 500 of them were trained in CPR. And we had a live, there was a guy who collapsed there in front of us during the training program. So it was like literally a live demo for everyone. Yeah. This is a reason from a student to the police to teachers to each and every person. Like if you're, we say 11-year-old because they have strength to perform CPR, everyone should be trained. So this emergency can happen anywhere.
Why students and police specifically? What were you thinking?
So students, because like, at a very young age, if they learn and they live for another 80 years or something, they know the skill and they will be more useful. And also the numbers, like, if you go into college, we train the entire GKVK college. At once we can train 500. We get huge numbers and we have the quantity of mannequins, and they do one-to-one training. It's not just a demo. They all get hands-on training. Because of the number of, I think we have more mannequins than the manufacturer. So no one has a thought. Like, if you go to any hospital, they have like maximum, any institution, they have like some 10, 15 max. So that is, because we have this huge advantage of having 1,000 mannequins, we can train high numbers. And we thought students are right cohort to train because they're everywhere, like they're at home, they can save a lot of people. And the policemen, because they're almost like they're always a first responders. Even before if there's an accident or an emergency, the first man to respond is police before the doctor or the ambulance comes. So we thought we should train the first responders, and they are dealing with all kind of emergencies everywhere. Like, it could be attempted suicide, it could be a road traffic accident or assault, any kind of medical emergency. They are the first people to respond. So we thought they should be trained. And it could be their colleagues, like, they perform very high stress jobs, and then if one of their colleagues collapses, they can do a CPR and save life.
Right. In India, if someone collapses on the street, bystanders just watch. What do you have to tell them?
I would say, like, if you're not learning CPR and basic life support, just do it right now. I think every minute or every second delay, maybe one life is lost. And reach out. You can reach out to us or reach out to anyone. Or some of the organizations, they charge 5,000 rupees per training, up to 8,000 rupees, and we do it free of cost. And you can walk into IAAT office and get trained anytime, or like, if wherever the closest possible place to train in CPR, reach out and train, because this is a life scale. It's not just a life scale, life saving. It's also a very, very essential skill. It could be your best friend. It could be your dad. It could be your grandfather. It could be anyone, But if you have this skill, you're almost like, saving one life is like saving one world. It will just make the entire life worth it, like, if you save a life.
During COVID, you ran a 42 crore relief operation with 700 volunteers from various parts of India, IITs, IIM, hospital, NGOs. Who called you to do this? Or did you just start this?
So this is a group of IITians who had formed a platform to bring in like-minded people to do something about COVID. And I and Sudeep Pillarisity, he's from IIT Madras, and we both are the co-founders of this COVID Day campaign.
Okay.
Where we ran this program. We had multiple initiatives. We started off with Seva Saviors campaign, where we donated the highest quality PPE and mask, N95 mask, to doctors and nurses in hospitals. We only donated to government hospitals, and we had our own internal matrix where we calculated for 7 days how many nurses, how many doctors, how much this need. And again, we literally 200,000 manpower hours were spent into this activity, and very high quality. Almost all my volunteers were IITians, or they were from BITS Pilani, IIM, or intensivist. So these were the very high quality volunteers we had. And if I say like we need best quality PPE, they used to go immediately into all the research. They used to find out where they are. They used to create a platform where we procure them and donate them. We got very good donations, and people during COVID, people were very sensitive towards this, and they donated, and A lot of organizations came forward, from American Canada Association to within India itself, quite a few. And a lot of IATians also volunteered to put money into this. We nearly 25 crore worth oxygen concentrators were given from Srinagar to Kanyakumari, from northeast to states. And we adopted 10 ICUs in Karnataka, where we trained all the ICU doctors. So we did it in phase one, COVID phase one, first phase in COVID. We did SOS, Save Our Saviors. Then we did Breathe India because of the oxygen demand, then Breathe ICU in the third wave. So yeah, it was a huge effort. There are a lot of initiatives that ran under this campaign. One of the important ones were Mission Cope, where we got like plasma donors during COVID. So we had 2 donors in Karnataka, and it was a joint operations between Karnataka government, HCG hospital, and ICAT when a COVID India campaign. So all 3 came together. I was heading Mission Cope, and we raised from 2 donors, we raised it to 2,000 donors. So hundreds and hundreds of lives were saved during that time. Yeah.
What did the government, you're a private limited company, ICAT. What did the government say when you were doing all of this? Were they just watching, or did they actually come in and lend a hand?
I think when COVID happened, absolutely there was no one system that worked and one system that watched. People complain you're not giving, there's no oxygenators, there's no oxygen, there's no mask. But I asked the people are you following the guidelines and protocols? You're partying, you're spreading COVID, and you complain. Moreover, what are you contributing towards this disaster? And no country in the world was prepared to face this disaster. So government worked as NGOs, we worked as private limited, people worked, a lot of everyone came together, including policemen, doctors, paramedics. Doctors were not even trained to be soldiers, but we stepped up and we became the first line in facing all these patients and putting our lives at risk as well. So I don't think so anyone watched each other. I think it is watching for each other.
Right.
You want to do a good work, let me see how I can support you. You want to do a good work, for example, as Mission Cope, Karnataka government joined hand with us. So, and when we were training all the government hospital doctors, they said, yes, please train them. And you're donating almost 1 crore worth equipment to taluk level ICUs. They'll ask all their doctors, all the paramedics and all the nurses to take the training program. So it was more in terms of working together than watching. So this is how the government recognized, and they walked with us, and we walked with them as well.
An air ambulance in India costs anywhere between roughly 2 to 10 lakhs just for one flight. Who can actually afford this?
Yeah. I know air ambulance sounds like a very expensive business, and in Madhya Pradesh, it's a free service, which was started by us. And we want this to be a free service in India. As I said, every 4 minutes a death in Indian road, nearly 16 to 20 children die on Indian road. And people who are losing lives are youngsters. And it should be a free service, especially covering the national highways and state highways where maximum number of deaths happen from road traffic accident. So if you ask me who afford this, 80% of our patients are middle class. They're not super rich. They are not HNIs. They are not politicians. So I think because they go to corporate hospital, and if they're very critical, almost they end up paying 20-25 lakhs. And air ambulance is almost 10 to 15% of the cost.
Right.
And if they don't get to hospital, them surviving, the chances are very bleak. So they put in this money to get, and again, it has to be done by a good team to take the patients in good condition for them to get further treatment as well. So although it looks big, but 80% of middle class patients of ours, they're able to, I think when it comes to life, people will spend and put everything together, pool in money and make this happen, because end of the day, life is precious and life is priceless.
Right. Hypothetically speaking, today, if I have to be airlifted anywhere within India, how much would that cost? and what are the procedures that I have to follow?
So, first and foremost, there is no fixed price because it depends on how many hours the aircraft flies. For example, if someone's in Raipur, they have to come to Hyderabad. If the aircraft is in Hyderabad, it does two legs, like goes to Raipur, it will fly to Raipur and bring the patient directly to Hyderabad. But if the aircraft is in Bangalore, then it has to go to Raipur, bring to Hyderabad, then fly to Bangalore if it's the base.
Right.
So the cost can vary as per the trip, but roughly it would cost around 8 to 10 lakhs.
Minimum.
No, for this sector, like if I'm talking about
okay, if you're
Raipur
doing
to
this.
Hyderabad, if we are talking about anywhere between 7 to 10 lakhs it will cost. Again, as I said, it all depends on the number of hours it's flying. Having said that, we are going to slash this cost down in a big way by strategically locating the aircrafts. So the number of hours, flying hours are reduced, and a lot of insurance companies are also now providing insurance. And if someone wants to use ICAT air ambulance, it's not just the people having medical emergencies. A lot of people travel. They travel for high-risk sports or even travel as tourists, especially senior citizens. They fall sick. They need an ambulance to come back. So they have to call our ICAT dashboard. There is a number. If you Google ICAT air ambulance, we get a number and just call that. We are 24/7 operational. Once the call comes, immediately the doctor will be on the call along with the operations team. We decide the aircraft, the medical team, equipments, and as per the medical condition of the patient, we mobilize a team. We mobilize a team anyway between in Madhya Pradesh when we were operating, we were taking off in 15 minutes by helicopter. But a fixed wing plane takes 2 hours for all the permissions because we have to we have to obtain lot of ATC and all those controls permissions from that. Flight plan has to be filed, so that will take 2 hours to take off. But if it's a helicopter, it can take off within 15 minutes.
Oh, wow. You spoke about insurance previously. Health insurance in India barely covers air ambulances. Is that insurance companies' failure, or the government's, or the industries?
I think it's a combination. I think because awareness is low among the insurance companies, there is a service that exists which can be utilized, and also awareness among people. Also, like until they face a situation, they'll not understand they would require an air ambulance. And we Indians are optimists. We always think like nothing bad's going to happen. And the third thing, of course, we need to require more support from the government in terms of at least making the emergencies in terms of trauma as road traffic accidents that should be fully supported by government, like the Madhya Pradesh is doing. So if we provide trauma emergencies as free, medical emergencies could be taken care by insurance or the combination of this. There is definitely a huge gap in terms of all of them coordinating with each other and also creating, having awareness.
Right.
But it's still a nascent market in India comparative to other services, still a growing market. And from what we started to now, we almost get more than 25-30 calls every day. So that itself, that this is without marketing. You might have seen, you don't see us anywhere. There's no brand building, marketing. We don't do any big media exercise. Whenever we get a media coverage, it's media approaching us because we've done some phenomenal transfer. It's never us calling the media to our office to give a statement. So yeah, people, we are building it. We're building a system where the flying will be shortened and insurance will be supported, and the government also will take up certain.
So you see it happening in a year or two, health insurance being covered for air ambulance?
Yes, it's a bit of an NDA.
Yeah.
Yes, I would think within next 1 year we'll have a huge way of this going.
Yeah. On a lighter note, you started so many organizations. Why don't you start your own insurance company?
That's a very, very good question.
Yeah.
Of course, we have explored that. All the IRDA registration, licensing, execution, it takes 2 years, and I think that's a bit of a we don't want to waste even a single minute in providing this service.
There are middlemen and brokers in this profession who charge desperate families a massive fees, and they send undertrained doctors. What do you have to say about this?
It is a market which has got we can't call the competition, where this is operated by a lot of brokers, aggregators, land ambulance companies, especially advertising as air ambulance, because today is a world of social media and marketing. Anyone can come on top. You putting money into Google advert. There are no regulations in terms of which doctor should go, who is a trained person. Any untrained personnel can go to attempt to try to bring person. These kind of brokers and aggregators come up with a website. All they need is a website and a phone, mobile phone, and they aggregate everything from medical teams to aircraft to equipments, and they do very, very under substandard work and put the patient's lives at risk. They take the bank on the emotional moment of the patient's vulnerable families, where they give them exorbitant price sometimes, then they undercoat, and then just before the aircraft takes off they will put them under pressure to overpay, all kinds of thing. I think probably some kind of standardization, regularization has to be brought in by government. Like if we from ICAT, like I was explaining how our doctors are trained for a year after the post graduation in MD, emergency medicine or anesthesia, critical care. Only these three segment doctors are employed after further training, after 1 year further training. But if you look at the other guys who call, they are every day they come up with a different name. Today they get a bad Google review, tomorrow they come up with a different name. So yes, I think there's a lot needs kind of our government has to really work hard on getting these guys under regulations.
In February 2026, an air ambulance crashed in Jharkhand. All 7 on board died, including the patient. When you heard that news, what did you think?
It was very sad. Of course, families, patient, crew, and everyone wiped out in that accident. When these air ambulance transfers, if you look at the world data, more than charters, crashes are more in air ambulance because a lot of decisions are made under pressure because of the patient criticality, or it could be pressure from the families, or they would just want to execute that mission and go home, or they just want to complete. So the safety is a paramount in any mission. And again, like when it comes to us, we in the UK as well, like we don't share the patient's data with the pilots. We literally create a barrier so that they don't make decisions to fly into bad weather when they have to, when they come under emotional, we don't want them to make emotional decision. Aviation, the topmost thing is safety, and the next everything else life comes, because we can't put a safety of 5 people on board to save a life. So yes, it is very disheartening, this particular accident. It always make you look back and feel and look at yourself and think like, okay, this could be one of us as well. But I think if we follow all the safety rules, I think we should be preventing them in future and standardizing the aircraft qualities. And then DGCA is very, very strict in terms of our private charter, and they've brought in much more stringent rules now. So and again, there are not that many crashes that are happening in air ambulance. So hopefully we don't have any more in the future as well.
DGCA flagged that many air ambulances using the aircrafts are very old. The recent crash that happened in Jharkhand, that flight was 39 years old. Is that a very common scenario?
See, in aviation industry, like old aircrafts are not like a problem, because if they're maintained well. When aircrafts undergo a major rehaul, entire aircraft is dismantled and put back together. So the engines, like it's not like car, like you run kilometers and it clocks in kilometers. And when the engine gets rehauled, it goes back to 0 hour. So if they are maintained well, age is not like such a big issue. I mean, we have flown in 25-year-old aircrafts, Learjets, but if they are maintained well, because the regulations says even without a bulb, if a bulb is not working, you can't take off. Aviation regulations are very strict, but people have to comply and make sure the maintenance are done well. I don't think so it's to do with the age, it's more in terms of the maintenance.
In aviation, there's a pattern called mission oriented pressure. Pilots flying in bad weather because the patient is critical and the family is desperate. I can understand the entire scenario. Does that culture exist in this industry?
Yes, absolutely. This is why I was telling you earlier that we don't share the clinical details with the pilots to make sure that there's a child, 6-year child, like let's go, it's fine. We need to go. The child will die. So pilots come under emotional pressure. Like, yeah, this is a child. Let me take some risk and go. Yeah, we have to totally separate them and to never put a pilot under pressure. We always say pilot's discretion for everything. We never ever put them under pressure. And again, like when we go to like in Madhya Pradesh, when we are operating, we used to just send a medical team first, or not an aircraft with bad weather, and they used to fly out and stabilize the patient, and then we used to mobilize. Or if we take a helicopter and go to see a very bad patient to retrieve, team and the equipment stay in that hospital overnight, stabilizing the patient until it is safe to take off. If we are not disciplined about this thing, yes, there will be crashes because there is a huge emotional pressure on people operating, both the doctors and the pilots as well.
Right. You're hanging on a thin line between emotions, business, and healthcare. How do you manage? Where do you put yourself in this position? And what do you prioritize?
Safety.
Okay.
Topmost safety is my team. If my team has to be safer. That's crew safety is the paramount importance. Rest, everything comes second. Because if you don't have your own teams, I mean, if your team is not safe, everything else is a big waste of time. The patient is anyway sick. He's in a hospital or somewhere in a place. He could be looked after there. But I should not be putting 4 people on board, their lives at risk to go and get one patient out. So more than business, more than emotional
Emotions.
pressures, that topmost thing that
Okay.
comes is always safety. Always safety.
Right. And you know what? One thing I've learned in this entire conversation with you, you actually can rely and bank on your team because they have been trained the way you want them to be trained under
Exactly.
your guidelines, under your structure.
Yeah.
So that's a win-win for you.
Absolutely. Training. And we just don't stop at training. We retrain, we run drills, we do debrief calls. Like after any difficult transfer, we have a debrief. So we run through the entire scenario and we see what was not done well and what is that we are going to do on the next transfer to correct that. So every single time we do a debrief meeting, there's a new point that is added onto either to the checklist or a SOP. We improvise literally day to day. We improvise. So the mistake that is done today, because we work in a very dynamic situation, it's a very dynamic field. Aviation is dynamic. Our patients are dynamic. We land in a strange airport. We take off from a different airport. We go into a hospital which we have never been into. It's not like a hospital like where we work in the same place with same security guards, and we are vulnerable as well. So we land in some reward somewhere and people are violent and they are angry at you or something, patient deteriorates, they can take it out on you. So we are always on our toes. It is extremely important to have this training. This is why we built this training program. So if you look at all the companies, they've come as a gap and a solution. There is a problem, we create a solution. They're all a solution based. They're not just come up like we do business here, let's do. No, there's a problem for Indian diaspora to get back home. Let's start a company in US which will help them all. There is a problem in Maldives, people in inhabited, 950 islands, they can't come to proper healthcare. Let's do that. So every single time we have faced a problem, we have brought a solution there.
Right. I feel this is the best way to run any business, not actually look at a business from a standalone point of view, but to actually find a solution for the problem that exists.
That's right.
In today's world.
That's right.
And that's exactly what you've done, Dr. Shalini Nalwad.
Thank you so much.
You brought the first HEMS helicopter to India during the Kerala flood as a private organization. Where was the government?
So, in fact, like, when the Kerala disaster happened, we were watching people dying, and government did a fantastic job. Air Force, fishermen, defense, and the local, like, bureaucrats and the officers, doctors, they all, like, especially when the 2018, the same flood had happened in USA. I think more people would be dead, but they were extremely good, like in terms of organizations rescuing people. At the same time, the entire Kerala was flooded, and there were even the roads were full of relief vehicles. And then Cochin almost was submerged. So Trivandrum was the only place. There were more than 1 million people spread across these relief camps. They had a named doctor, and then the doctors were not essentially like trained to be critical care doctors, emergency physicians. They could be anyone, like microbiologists or dermatologists. They will not know how to manage critical patients. So government requests us to come and operate there to airlift these patients from different parts of Kerala. So we put a helicopter in Chenganur, and we converted the National Health Mission Hospital, which government provided us, as a command center. Within 4 hours, we had established a command center. We connected it with all the relief camps. We followed a track and trigger to airlift patients. Government like supported us, but not financially. Yes, I think they had other priorities to act upon as well. And they said, like, we don't have money for this operation, but this is essential to rescue people. So, but again, when it came to Chhattisgarh, they funded this. But when it came to Kerala, everything was done on a charity basis.
What is a HEMS helicopter?
Helicopter emergency, HEMS helicopter?
Yeah.
HEMS helicopter is a helicopter which is converted into air ambulance version, like,
Okay.
to emergency.
Right.
HEMS stands for Helicopter Emergency Medical Services.
Okay.
So if you look at a helicopter, they have charter seats.
Right.
But if you convert them into a flying ICU, it's called a HEMS helicopter. For stretcher and all the equipments on board.
You were the one who...
And also
got
we need
one.
a special avionics for that.
Okay.
So every helicopter can't do HEMS. Again, we did the first HEMS operation in India during a national disaster.
That is the Kerala floods.
Yeah, that's the Kerala floods.
Okay.
We were the first to do a national disaster. A private
Right.
helicopter private HEMS helicopter to be deployed was first time in India.
DGCA, AOC approvals take 6 to 8 months. In a country where people die waiting for emergency transport, how many patients are lost in this trap?
I wouldn't call it a trap. Aviation is a very regulated area. I understand that they have to be very stringent in terms of giving permissions and granting permits, aeromedical transport, STC clearance, registration. Yes, it takes nearly 3 to 6 months. Probably that is a time wasted. I think DGCA need to have a dedicated team.
But one thing I feel you can feel happy about is it's at least faster in the Indian legal system. Yeah.
Don't want to compare Indian legal system. People don't die in legal system, but here people die. As you said,
Time
as you
frame.
quoted, like, it's very time critical, and every minute we waste, like, every 4 minutes is death on Indian road. I think we started at 11, 11:30. It's nearly 1:15, like, 1. And how many people are dead? 165,000 people die on Indian roads. You can, in a year. So just imagine, between you and me talking, every minute's a neonate, a newborn baby dies in India. Every 4 minutes a death. And we don't even know, we don't have a data of how many people are dying of cardiac arrest or cardiac emergencies. How many mothers die. We have no data, like, to look at properly. So, so we between us spending 2-3 hours, hundreds of people are dead. Where they should not be dying. The lack of care, lack of a speed, lack of a skill to reaching them. You can build 100 hospitals, but it's not easy to fill them with a manpower who are skilled. I mean, if you ask a neurosurgeon to go work in a village, why would he go work in a village or even a district headquarters? He wants to be in Bangalore. I mean, you and me we are living in Bangalore for a reason. Your parents are living in Bangalore because they want to give you a good education. They want to have the lifestyle. It's a choice. But dying is not a choice. So these helicopters are the solutions to respond and bring them to the the hospital has to be taken to them, than building a hospital there.
Right.
And then bring them appropriate time as golden hour. We call it golden hour. Like, Western world is going towards platinum minutes. Yeah, we're still not able to comply with the golden hour. People having an accident in Taluk headquarters, by the time they reach Nimhans or Victoria Trauma Center, 6 to 7 hours are spent and they are gone. Mud. So from gold, we is going towards mud. So government, especially, of course, you're addressing the DGCA, probably there should be a dedicated team who can expedite lots of things, although they have made a kind of online portals for a lot of things, but still there are kind of a few gaps where it could be expedited, done. We were stuck once, like with a helicopter, one of the permissions, we took them 3 months to give us the one very, very simple protocol. I feel like I understand because of the strict regulations they have to follow, and they're guided by them and they have to stick to them. But at the same time, a dedicated team for air ambulance will be huge help in terms of bringing it's a nightmare if I think today I had to bring an aircraft here, because aircraft is is a cash intensive asset, and you put in money, and if you if the aircraft is sitting grounded even for a month, it's a huge loss. And then loss of money and loss of business and loss of life as well. So there should be a better system. They need to come up kind of gear up to give these permissions much more faster than they're giving.
Because you spoke about aircrafts, how many aircrafts do you have in your inventory right now as we speak?
So within India, we have there are 8 aircraft which can do air ambulances. They need to have AMT, Aeromedical Transport Certificates. In Abu Dhabi, we operate on a twin-engine jet called Challenger 605. And then we also use a lot of commercial planes for international transfers, patients who can't afford dedicated air ambulance.
Got it.
We have a hotline with Emirates. We have a great team with the Turkish Airlines we work with, and also with the Air India, Etihad. So it is like region-wise, we have a lot of tie-ups. And we have a tie-up with the company in Miami, the aircrafts, and the Lucknow and Philadelphia was done on that aircraft.
Right.
So we have relationship with different kind of contracts within India and also outside India.
Yeah. So the 8 aircrafts that you have in your inventory in India today, so your company has bought it, or
No, we don't own any
You don't-
assets at this point of time. Probably in a few months. In aviation, kind of a mistake we do is get into buying them, because until and unless you understand them, understand the entire operations, MRO, how we manage the fleet, there are different kinds of
you lease them.
so there are different kinds of relationship we can have, like a dry lease, there's a wet lease, there's a damp lease. Then dry lease is when we bring them from outside India. Some of them are purchased. There are different models we can work under. So we kind of use different models to work.
What is the single policy change, if someone in the Ministry of Health or Civil Aviation is watching this, that you would like to tell them regarding air ambulance services in India today?
Make HEMS a free service, and no citizens or no citizen of India should lose their life on Indian road, and no one should be left behind. Every life is priceless, and it's not a huge cost doing the service, helicopter emergencies. I think that's what I would request entire Indian government, to make HEMS a free service for Indian citizens.
If everything goes right, what does Indian medical emergency system look like in 2035? What would it look like?
If everything goes right, and we have a plan of inducting eVTOLs, electric vertical takeoff and landing, like electric planes.
Okay.
So we are designing e-planes, like a company by UbiFly. We have a MOU, and we are designing them to become air ambulances. So when these eVTOLs in air ambulance configuration, we are planning to have one per district. There's 788 for India. This is going to revolutionize the entire rural healthcare system. This is going to be a beautiful bridge between a land ambulance and a helicopter or an air ambulance. So that is one plan. And we already done a drill on a drone, where we have deployed drone from Mandya Institute of Medical Sciences, where I come from, to my ancestral village. 12 kilometers was covered in 10 minutes. We transported defibrillator, like, which is used in the CPR. So this was transported from MIMS to Chikmulgud village, that is my ancestral village, in 10 minutes, and we did a drill of saving a life who had a cardiac arrest
drone.
by drones. So this drone will deliver, because you can't have a defib in every small place. So these drones will be, and also they can deliver organs, they can deliver blood, they can deliver emergency medications, snake venom, vaccines, biopsy material. There are 100 of things like these drones can do. So a drone, eVTOLs, helicopters, and fixed wing planes, and land ambulances. We would like to put the full circle on this. And as I said, Germany has got 1 per million. We hardly have 2 or 3 helicopters in India, maybe 2, which are doing emergency medical things. So we need, you can imagine the number we need. And even if we achieve 10% of that in up to 2035, I think we are game's done.
Right now, if someone has a cardiac arrest in a village, what would happen to them right now?
Forget about we are in a village. If a cardiac arrest happens in this room, I have a cardiac arrest. What would you do? You'll ring an ambulance, and closest ambulance maybe 15 minutes away. By the time ambulance comes here, I'm dead and gone. Because every minute injury to the organs, brain happens after the cardiac arrest happened, the heart stopped. So if you can imagine in Bangalore city, sitting in one of the closest locations to any hospital here, cardiac arrest happens, I'm dead, definitely dead, and no one can save me here.
So the first
and foremost
skill is CPR.
CPR, yeah. If someone learns CPR, and it's a very easy skill, and we have designed it in a very organized manner. The way we teach, no one ever can forget that in life. And every 2 years, they need to, the license has to be renewed. So, I don't think so anyone in the village will survive the cardiac arrest today.
The flying ECMO program we spoke about is only one of its kind in India. And you host one of the ECMO programs. Is there a world where this becomes something every country has access to, not just the wealthy ones?
Yes. In UK, in Taiwan, in Australia, they do it pre-hospital ECMO. So that means, like, if I have a cardiac arrest here, ECMO team will be mobilized by helicopter, and they put me on ECMO. They create a heart outside my body, and they take me to a hospital where my survival is very good. So that is called eCPR. Sorry, ECMO CPR. It is a free service for people in, as I said, like Australia and UK and a lot of nations in Germany and Sweden. It's a free service. Yeah.
You've set 2 world records, built 7 organizations, you've flown into war zones. What is still left undone? What's the thing that keeps you up at night? Not fear, but ambition?
So I'm not done yet. There is, I think we're just scratched the surface. There's so much to do. I think, covering Indian sky with multiple helicopters, saving lives. That is the ambition. That's the vision. And build a very high quality air ambulance service, which will be the largest with the best standards for the entire world. That is a vision. And for India, of course, India always takes a priority to cover Indian skies with HEMS helicopters, flying and rescuing people.
Being a woman in all of this, walking into conflict zones, commanding aircrafts, sitting in rooms with generals and ministers, has it ever been used against you?
I think, I never felt that. Probably there is a bit of an undercurrent, but if you know your subject well, and if you know what you're speaking, and you're prepared well, I think no one can ever underestimate. Also, it gives a bit of an advantage as well sometimes, people are polite when a woman speaks, and they listen as well. So far, I haven't really got any negative things. Probably because I'm well prepared and I know my subject, and I know what I'm doing as well.
Absolutely.
So if you're well versed with what you're doing, I don't think so any man will put you down.
You have a Lifetime Achievement Award at such a young age. Does that feel strange?
It does feel strange. I I think my first lifetime achievement award was like some 4 years ago, and I thought, like, is it it? Is that it? Like, have I done everything I was supposed to do? But again, these awards are just a recognition of good work, and it's a responsibility as well. It's not just a recognition. So when you take these awards, I always feel a lot of pressure on my shoulders. I feel like, to live up to that, not to disappoint people, take it ahead, fly the flag higher. And again, flying flag higher means saving life, where I can't compromise on that. So it's more of a responsibility and pressure when we receive these awards.
Has all of this cost you something personally that you had to give up to go through and get these awards? You get 2 awards a week and almost around 500 to 600 felicitation programs already done for you. So did you have to let go of something?
See, it's not we're going to a particular award to take award or feel recognized. It's more in terms of motivating and inspiring people as well. So I get invited to some remote, like, district headquarters, for example. It could be Tiptur, or it could be Shumaga, or it could be a smaller village, but in a very big congregation of people. And when when I go there and address, and I go, I mean, there's nothing like, it is a time you need to dedicate. It's a personal time you have to sacrifice, but it's also a responsibility of inspiring people and motivating them. And that's how you are looked at to be an inspiration. So as a responsibility, I have to go. It's not to take award, also to give her that motivational talk and show a lot of bright paths for today's young generation, and then get them to focus and at least be a role model somewhere for them to see, yeah, if an ordinary person from Mandya can do this, coming from a tier 2 city, I think we all have hope to get somewhere. So I think that is what it is about. Yes, personal sacrifice is always there. There's always a collateral damage. You will have there a lot of weddings I get blacklisted to. In my own families, they don't even consider that I'm going to be there. Sometimes I don't even get invited, but in a good way. So it's not a bad busy; it's a good busy. So yeah, you'll have to sacrifice a lot of things. Like, you, as I said, you go to Paris and you don't get to see Eiffel Tower. That's a sacrifice, or it can take it as like a routine work. Yeah, you have to work day and night. A lot of things. You have 24 hours. You can only do size small, right? Yeah. You can cut that as much as you want. Edit it. He has very difficult questions. That's the problem. And very intelligent questions as well.
Last question. You watched bombs drop from a landing plane. You've had a car race at your aircraft at full speed. You've kept hearts beating at 30,000 feet. What still scares you?
Life. Losing a life scares me. And death scares me. Or not able to save someone will scare me. That is the most scariest thing. And the team safety, of course. Like, every single time a plane, there are times when the plane is landing after finishing the mission at 2, 3 in the morning. I somehow can't sleep until all the planes have landed safely and the teams have taken the patients and they reached the hospital. Like, you just can't relax till then. No matter how much we scale, how much we build, I think patient safety and lives always keeps you awake.
Right. But doesn't that keep you on the edge? Fear, risk, adrenaline rush. Just on a contrary note, I feel the more you fear something, the more likely it's going to happen. So
it's it's not a fear that you're scared of it. It's just it's not more than a fear. It is the
safety precaution.
It is a responsibility.
Right.
It is a responsibility. Like, there's a patient landing. There is an aircraft landed safely. Did the patient reach the hospital safely? This is more than a fear. It's a responsibility. And because we are handling such critical missions, and also the aviation is such a sensitive field, it's not easy to just say, okay, whatever, and just ignore it. Absolutely. Or automate yourself not to think about it. and you're a doctor, and you're always a doctor, no matter what. You are into entrepreneur, you're a politician. At least for me, I'm always a doctor first, and the patient comes first to me. So you always worry about patient more than a fear. I think it is a concern and responsibility.
Absolutely. Dr. Shalini Nalwad, founder of IAAT Air Ambulance, holder of 2 world records, India's first flying ECMO doctor, and someone who flew into war zones so that someone else's family member could come back home safely. Thank you so much for being on Journal of a Leader. It was a great honor for me to host you, and thank you so much for taking the busy schedule of your day and coming in such a short notice and providing your precious and valuable time. It means a lot to me and my team behind Journal of a Leader.
Thank you, Anshul. It's been a very thought-provoking podcast I've ever attended, and thanks for all your intelligent questions. And it was really good. I kind of for a minute the things which I first time I'm thinking as well. Thank you. It was brilliant, and it was great speaking to you. And thank you for all your team for this.
Yeah,
Thank you.
thank you.